Dear students, our next class is cephalosporin. It's a beta-lactam antibiotic, one of the most commonly used antibiotics in clinical practice. We will see the mechanism of action, classification, antimicrobial spectrum, as well as a few points about each agent in this group. Cephalosporins are beta-lactam antibiotics. We have certain other beta-lactam antibiotics like penicillins, monobactams, as well as carbapenems. So the common thing in all these antibiotics is a beta-lactam structure or beta-lactam ring in their structure. So here in cephalosporin, a beta-lactam ring is fused to a dihydrothiazine ring. Initially, it's obtained from a fungus known as Cephalosporium. Later, different semi-synthetic preparations are formed. So the change or the substitution of different chain at the position of 3 as well as 7 leads to the formation of semi-synthetic cephalosporins. All beta-lactam antibiotics, they act by inhibiting the bacterial cell wall synthesis. So the bacterial cell wall contains peptidoglycan layer. This peptidoglycan layers contains alternating chains of N-acetyl muramic acid and N-acetyl glucosamine, and there will be cross-linking between the adjacent chain. This N-acetyl muramic acid is a pentapeptide chain. It contains L-alanine, D-glutamine, L-lysine, D-LA, D-LA, and there will be cross-linking between the L-lysine of one chain to the D-LA of the next chain. So this cross-linking, and there will be a removal of terminal D-LA. This cross-linking provides stability to the bacterial cell wall, and the cross-linking as well as removal of terminal DLA is possible with the help of a transpeptidase enzyme. This transpeptidase enzyme and its associated proteins are known as penicillin binding proteins. So if you administer a beta-lactam antibiotic to a bacteria, this antibiotics goes and inhibits the transpeptidase enzyme. So the cross-linking will not take place. The structural integrity of the bacteria is lost, and the cell wall deficient forms of bacteria are formed. The cell wall deficient forms are osmotically unstable, so there will be lysis of the bacteria. There are some basic structural differences between the gram-negative as well as gram-positive bacterial cell wall. In gram-positive bacteria, the cell wall is almost entirely made up of peptidoglycan layers. So the beta-lactam antibiotics are very effective in the infections caused by gram-positive organism. But in contrast to that, in gram-negative bacteria, the cell wall contains alternating layers of lipoproteins as well as peptidoglycan layer. Only those antibiotics which are able to pass through the porin channels in the outer lipid membrane goes and acting on the peptidoglycan layer and inhibit this. So the gram-positive organisms are more susceptible to beta-lactam antibiotics. Bacteria developed different mechanisms for developing resistance to these beta-lactam antibiotics, which includes the production of certain beta-lactamase enzymes. These beta-lactamase enzymes goes and destroy the beta-lactam ring of the antibiotics, so there will be destruction of the antibiotic. And the second mechanism is alteration in the target proteins, for example penicillin binding protein. So these beta-lactam antibiotics cannot bind these penicillin binding proteins there, so the action is not taking place. And the third and fourth means there will be impaired entry as well as increased efflux or exit. This is the schematic representation of the bacterial resistant mechanisms. So the production of inactivating enzymes or the alteration in the target, increased efflux or decreased entry, these are the resistant mechanisms. Moving on to the classification of cephalosporins. The cephalosporins are divided into 5 generations. This classification is based on the sequence of chronological development as well as based on their antimicrobial spectrum. So the first generation includes cephalexin, cephadroxil, cefazolin. Among these, cefazolin is a parenteral preparation, and cephalexin and cephadroxils are oral preparations. And second generation, cefuroxime, acetyl, cefaclor, cefprozil, they are acting through the oral route, and cefuroxime, cefoxitin, cefotetan, and cefamantol. These are parenterally acting cephalosporins. The third generation oral agents are cefixime, cefpodoxime proxetil, cefdinir, ceftibutan, ceftamed pivoxil. And the parenteral preparations are cefotaxime, ceftriaxone, ceftizoxime, ceftazidime, and cefoperazone. In the fourth and fifth generation, we have only parenteral preparations. We do not have any oral preparations. So the cefepime and cefpirome are fourth generation members, and ceftaroline and ceftobiprole are fifth generation members. So these fifth generation members are also active against MRSA, methicillin resistant Staphylococcus aureus. Now we will see the antimicrobial spectrum of cephalosporins. This is a general outline of their antimicrobial activity. We will see a few points about each agents in the coming slides. So the first generation members are more active against gram-positive cocci than the gram-negative organisms. The second and third generation, they are more active against gram-negative organisms. The fourth generation members have additional anti-pseudomonal activity with that of second and third. The fifth generation is also known as anti-MRSA. Coming to the first generation cephalosporins, as I already said, they are more active against gram-positive cocci than gram-negative bacilli. These agents shows good activity against streptococci as well as methicillin susceptible Staph aureus, but they do not have any activity against enterococci as well as MRSA and Staph epidermidis. Moderately active against E. coli, Klebsiella pneumonia, mirabilis, Moraxella catarrhalis, and anaerobes in the oral cavity except Bacteroides fragilis. Thus, the first generation compounds are preferred in skin and soft tissue infections by the susceptible organisms, and the serious infection caused by methicillin susceptible Staph aureus, and cefazolin is preferred in perioperative surgical prophylaxis. Coming to the second generation cephalosporin, these groups is more active against gram-negative microorganisms with respect to first generation compounds, and even certain members like cefoxitin or cefotetan, they are active against anaerobic organisms. But on comparing their activity with third generation, they are inferior. These agents shows good activity against E. coli, Klebsiella pneumonia, mirabilis, Moraxella catarrhalis as well as Haemophilus influenza. And against Bacteroides fragilis, they have moderate activity. And the second generation compounds are effective for the management of upper respiratory tract infections like sinusitis or otitis media, and cefoxitin or cefotetan, they are effective in gynecological infections. Cefuroxime attains higher CSF concentration, so it was preferred for meningitis. But nowadays, because of the availability of superior third generation compounds, its use has been declined. So now this cefuroxime only preferred in meningitis cases where the third generation compounds are found ineffective. And this cefuroxime is further effective for the penicillinase producing Neisseria gonorrhea infections as a single dose IM therapy. Cefuroxime acetyl is an ester of cefuroxime which is effective through the oral route, and the cefoxitin as well as the cefotetan, these are the second generation compounds effective against anaerobic infections. Moving on to the third generation cephalosporins. Just like second generation compounds, these compounds also show high activity against gram-negative microorganisms. Few agents like ceftizoxime or cefoperazone, they are active against anaerobes also. So these third generation compounds are effective for the management of E. coli infections. Ceftriaxone and cefotaxime show their activity against streptococci, and in general these third generation compounds are highly resistant against the beta lactamase enzymes produced by the gram-negative organisms. Now a few important pharmacokinetic features of these third generation compounds. We can administer this drug through the oral as well as parenteral route. All these compounds are well absorbed from their site of administration, and they attain and few agents attain very good concentration in CSF. For example, ceftriaxone, cefotaxime as well as ceftazidime. So we can prefer this compound for the infections of meningitis as well as encephalitis. And among the third generation compound, cephalosporin is the only agent which is excreted mainly through the bile. And about metabolism, cefotaxime is deacetylated to a metabolite. This metabolite has less antimicrobial activity with respect to its parent compound, and other third generation compounds have no appreciable metabolism in our body. The major route of excretion for this compound is renal route. There are certain exceptions like cephalosporin and ceftriaxone. Cephalosporin excreted through the bile and ceftriaxone has a mixed excretion. Probenecid, they inhibits the renal tubular secretion of the cephalosporin. Probenecid also inhibits the secretion of penicillins also. So the probenecid increases the duration of action of these compounds in our body. Cefotaxime is beneficial for the following infections. For example, meningitis by the gram-negative bacilli, typhoid fever, and penicillinase producing Neisseria gonorrhea causing urethritis, hospital acquired infections and septicemia. Ceftriaxone is beneficial against Bacteroides fragilis. About ceftriaxone, this agent has a long duration of action and it has got the half-life of around 8 hours. It has got excellent penetration into the CSF and it has a mixed elimination. That means elimination by both urine as well as through the bile route. So the ceftriaxone is preferred for the management of bacterial meningitis, multi-drug resistant typhoid, complicated UTI, abdominal sepsis, gonorrhea. But the use of ceftriaxone has been associated with certain reports of hypoprothrombinemia, which may result in bleeding. And about ceftazidime, this is the third generation cephalosporin showing highest activity against Pseudomonas aeruginosa. The indications for its use includes febrile neutropenia and the infections in patients with hematological malignancies or burns. And the specific side effect associated with its use includes neutropenia, thrombocytopenia, elevation of liver enzyme like transaminase as well as elevation of blood urea. Coming to the cefoperazone, this agent also shows good activity against Pseudomonas aeruginosa, Salmonella typhi and Bacteroides fragilis. The side effects associated with its use includes disulfiram-like reactions with alcohol, bleeding tendencies as well as diarrhea. Cefixime is preferred for the infections in respiratory as well as in the urinary tract. Diarrhea is the commonest side effect associated with its use. And the features of ceftibutin as well as cefdinir are almost similar to that of cefixime. Next agent is cefpodoxime proxetil. It's an orally active ester prodrug of cefpodoxime, active against Staph aureus, Streptococcus pneumonia, Haemophilus influenza and Moraxella catarrhalis. So this cefpodoxime is effective in respiratory, urinary as well as skin infections. Coming to the fourth generation cephalosporins, they have high activity against gram-negative microorganisms than gram-positive ones. Additionally, it has got activity against Pseudomonas aeruginosa and Staphylococcus aureus, but there is no activity against MRSA. And this group is resistant to the degradation by beta-lactamases produced by the resistant organisms. Thus, they are active against certain bacteria which are resistant to the other groups. This group has better penetration through the porin channels of gram-negative organism. That's why they are better active against gram-negative organisms. These agents are preferred for hospital-acquired pneumonia, septicemia as well as neutropenia. We have two members in the fourth group, cefepime and cefpirom. Cefepime, it attains higher concentrations in the CSF. So these are preferred in the neurological infections, and it has renal elimination with a half-life of around 2 hours. It also shows excellent activity against E. coli and methicillin sensitive Staph aureus. Cefpirom is the second agent. Because of its high penetration through the porin channels of gram-negative organism. This agent is also preferred in gram-negative infections. But on comparing to the third generation compounds, this cephalosporin has good activity against gram-positive organisms also. Moving on to fifth generation cephalosporins. It's also known as anti-MRSA cephalosporins. They bind to low affinity penicillin binding proteins of MRSA as well as Streptococcus pneumonia. Usually the resistant organisms penicillin binding protein shows low affinity to these beta lactam or any other antibiotics, but our fifth generation they even bind to these low affinity penicillin binding proteins and exhibits their action. They also have enhanced activity against gram positive organisms. So these agents are preferred in bacterial skin infections as well as in hospital acquired infections where the resistant cases are more. The fifth generation contains two members, ceftaroline and ceftobiprole. The ceftaroline is administered in a form of ceftaroline fosamil. It's a prodrug and it's converted into its active form in the body. This agent is preferred for mainly the complicated skin and soft tissue infections and the community acquired pneumonia caused by MRSA or resistant Streptococcus pneumonia. And this agent has a minimal protein binding in our body and is mainly excreted through the kidney. Ceftobiprole medocaril. This is the second agent in the fifth generation cephalosporin. It is also a prodrug and it's converted into an active metabolite in the body. This agent has very minimal metabolism in our body. So most of the time it is excreted unchanged by the glomerular filtration. It has got a half-life of around 3 hours, mainly preferred in community acquired pneumonia as well as in MRSA infections. Coming to the adverse effects of cephalosporins in general, the most significant adverse effects is hypersensitivity reactions which may manifest as rashes, angioedema or even anaphylaxis. 10% of the people who are sensitive to penicillins also shows cross sensitivity to cephalosporins. So the pain after injection is seen with many cephalosporins and few case reports of nephrotoxicity following injection of cephalosporins are noted. Most of the time this nephrotoxicity is accentuated when a cephalosporin is using with aminoglycoside antibiotic. To conclude, cephalosporins are bacterial cell wall synthesis inhibitors. We discussed about 5 generations of cephalosporins and important points about each member. They are mainly preferred in skin, soft tissue infections, respiratory infections as well as in urinary infections. So they shows broad spectrum of activity when we are moving from first to fifth generation, and the last generation compounds shows great resistance towards the beta lactamases produced by certain resistant organisms. So that's all about cephalosporins. Thank you.